you. So I'm very pleased to welcome you to this webinar, which will focus on how to best select control conditions in research on music interventions for pain management. So we have three experts who will address this difficult question today for 20 minutes, followed by 5 minutes for Q&A. I am Isabelle Peretz, professor of psychology at University of Montreal, and I will chair and moderate this webinar. And I'd like to disclose right away my perspective on today's questions regarding the selection of an appropriate condition, because I think it's a huge challenge. Because I think that nearly everyone believes or strongly believes that music will help them to cope with the pain. So just by the fact that they believe it will reduce the sensation of pain, then it will happen. That is, it is what we call a placebo effect. So allow me to be provocative, and for sure we will discuss that for the whole time, that music might be the ultimate placebo effect. In other words, you really need to be quite clever to come up with a condition that will be able to be comparable to music. And I'm very curious to hear what are your solutions. So without further ado, I will introduce the first speaker, who will speak for 20 minutes with 5 minutes after that. It's Kenneth Freedland, professor of psychiatry and psychology at Washington University, who will share today his vast experience in clinical trial methodology. So it's going to be a methodology aspect. Then we will have Luana Colloca, and to end up with Sheri Robb. So, Dr. Freedland, the floor is yours.
You are muted, Dr. Freedland.
Okay, can you hear me now?
Yes, we can.
Great, okay. Thank you very much. I am here today to talk about comparators for mechanistic trials of music-based pain interventions, although I'm going to stray into some other kinds of trials as well, briefly. I have research support from NIH and foundation support, but nothing else to disclose. The learning objectives for my talk today are to define the primary purposes of several different types of music intervention trials, to identify comparators that match these purposes, and to talk about adopting contemporary comparator selection models for these types of trials. There are a number of different ways to classify trials, such as, for example, the FDA's four-phase framework for drug trials. You've all probably heard about the explanatory to pragmatic continuum for trials that serve different kinds of clinical purposes. There are superiority versus non-inferiority trials, and there are other ways of classifying trials as well. For the purposes of the talk this morning, I'm going to divide trials into clinical trials and mechanistic trials. And I'm going to further subdivide the mechanistic trials into ones that I call residual effect trials and mediational trials. Both different ways of attempting to get at mechanistic questions about music-based pain interventions. And the key take-home message from all of this is that the optimal comparator for any of these trials is one that has the characteristics that best fit the primary purpose of the trial. And I'll be mentioning this over and over again. The primary purpose of the trial is a really key consideration, and something worth thinking about. Well, what are the characteristics that you might consider? There are 7 key characteristics of comparators in RCTs, but 3 that I want to focus on today in particular. The formidability of the comparator is concerned with how much pre-post change the comparator induces. And so the more the comparator induces change in the outcome, the harder it is for the intervention to outperform it. Clinical relevance is how closely the comparator corresponds to real-world interventions, services, or programs. In other words, how similar or how related it is to treatments that are actually provided in the real world. And then there is resemblance, and this is how similar the comparator is to the intervention to which you are comparing it. These are three characteristics that we need to focus on today. The primary purpose of the RCT is the most important consideration when you choose the comparator for a trial. And for most clinical trials, the primary purpose of the trial is to test a superiority hypothesis. It's not always the case, but typically it is. You're asking, does my intervention produce a greater benefit than some alternative? And so that raises the question of which alternative, or superiority to what? It's not a meaningful question unless you give some thought to what you are comparing to and asking superiority to what. This can be a very challenging question, though. The clinical relevance of the comparator is the key in clinical trials. Now, in some cases, there may be more than one clinically relevant possibility. There may be several different treatments out there that are already evidence-based or evidence-informed. In other cases, there aren't necessarily any specific clinically relevant alternatives against which to compare an intervention. And nevertheless, there may be clinical services that are brought to bear on whatever problem it is that you're trying to address. And so comparators with high clinical relevance make clinical trials clinically informative. If your comparator has low clinical relevance, then the question you are asking becomes questionable. Now, most clinically relevant comparators may or may not resemble the experimental intervention. The comparator may be quite different in many different ways from the intervention, and it may or may not be very formidable. Those are less important considerations in a clinical trial than whether the comparator is clinically relevant. So let's look at an example of a clinically relevant comparator where there is no specific evidence-informed intervention that's been widely implemented. And in this case, let's look at poor quality of life in patients with heart failure. Whatever patients actually receive in the real world is usually called usual care, or sometimes treatment as usual. Now, usual care has some limitations as a comparator. For example, different patients may be getting different kinds of treatments. Some patients may be getting nothing to help their quality of life. Nevertheless, usual care is, by its very nature, very clinically relevant. So in this recently published study by Beret et al., the population was patients with heart failure living at home. The intervention was classical music, and they compared it to usual care. And they had quality of life as a primary outcome and several other outcomes as well over a 3-month time frame. So this is a trial where usual care made sense because there isn't really a standard treatment for this problem. Let's look at a second hypothetical example in this case. Let's say that cognitive behavior therapy is the standard of care for these problems. It isn't, but let's just say that it is. The intervention that we want to test is classical music, and we're comparing it then to CBT because that is what people are hypothetically getting, and that's the standard of care. Now, you'll notice one thing is that the classical music has a different dosage. It's done daily for 3 months, whereas the CBT is done in 8 sessions. And so it's different in terms of the dosage or the amount of contact or whatever. Interestingly, there are 2 different ways to think about why you would do a trial like this, what the purpose is. One is you may be thinking that I want to see if I can replace CBT, this burdensome therapist-intensive intervention, with classical music. So that's a replacement design. Or you may be thinking that classical music might be a nice enhancement to cognitive behavior therapy and would improve outcomes above and beyond CBT alone. In either case, CBT alone is the comparator. So here what varies is the intervention, not the comparator. Before we get into mechanistic trials of music interventions, I'd like to take a quick look at the logic of typical drug trials. Now, the primary purpose of a double-blind, placebo-controlled drug trial is to estimate the pure, unconfounded effect of the pharmaceutical chemical of interest. And the strategy that's almost always used is to compare the drug to a chemically inert but otherwise identical pill, and also to provide identical clinical management to both groups. And so there is a assumption of additivity, that these different influences on the outcomes are additive. And so the total effect equals the effect of the chemical plus the placebo value plus the clinical management. And therefore, by algebra, you can determine the clinical effect is equal to the total effect on the outcome minus the placebo and clinical management effects. And so it looks like this. You can sort of with a pill placebo, you can extract the pill's placebo effect. You can provide identical clinical management to both groups because nobody knows whether the pill is the placebo or the actual drug. And by doing that, you can see whether the chemical itself has a residual effect above and beyond the placebo and clinical management effects. That's if the additivity assumption is correct. It's not always correct, according to some research that Dr. Colloca and colleagues have done. But usually it can be assumed to be correct. Now, it is the property of resemblance that makes double-blind, placebo-controlled drug trials possible. It's perfect or nearly perfect in most drug trials. There are exceptions, but it comes close to perfection. Now, there is a trade-off in doing that, in that the comparator has relatively low clinical relevance. Most of the time, for most medical problems, doctors are not giving placebo pills. And so it's not a very clinically relevant comparator, but it does enable you to look at the chemical effect. Now, the residual effect type of mechanistic trial of non-pharmacological interventions, such as music therapy, the question being asked is similar to the question being asked in a drug trial, which is, how large is the specific effect of the intervention's active ingredients? There's a similar additivity assumption, but there is a big problem when you try to apply this to most non-pharmacological interventions. It is that perfect or near perfect resemblance is essential for this to work, and it's impossible to achieve in the majority of non-pharmacological intervention trials. There are some exceptions, and some kinds of music trials may be exceptions. Just to give you a couple of recent examples, Legenbauer et al. Published recently a study of bright light therapy for kids with severe depression. And what they did was they compared an actual bright white light, which is known to have therapeutic effects in seasonal affective disorder. They compared that to a different kind of light in the same kind of a box, in the same kind of circumstances, but it's known not to have any therapeutic effects in these other populations. It's a dim red light. And so there's a high resemblance. It's not perfect, but it's pretty high resemblance between the bright white light and the placebo dim red light. One closer to home for music researchers, there was a trial in 2021 where a special sequence of music, I'm not familiar with this, but apparently starting with a stimulating rhythm and going to a slow rhythm and then ending up with a moderate rhythm. That was used to help calm people down during cataract surgery. It was compared to wearing the same kind of headphones with the same kind of instructions, but with noise cancellation instead of with the U sequence. That had fairly high resemblance. They could have had even higher resemblance if they'd used some other kind of music, or maybe the music sequence, but done in the wrong order. That would have been an even higher resemblance comparator. So let's look at a hypothetical trial with the kind of problem that I was referring to. This is a common kind of strategy using some sort of attention control condition for a psychotherapeutic intervention. In this case, we have patients with pain-related depression. They were given interpersonal therapy for 12 sessions, and the investigators thought, well, we better have something that kind of sort of resembles interpersonal therapy and has 12 sessions so that we can equate the amount of clinical attention with the same outcomes over the same time frame. The problem with this is the resemblance is qualitatively low despite the plan for quantitative similarity, the equal number of sessions. And it typically turns out that the equal number of session plan doesn't really work out in practice because people get sick of the fake intervention and drop out of it. It has very low clinical relevance. Health education is not really used for this problem. And it's of uncertain formidability. It's probably greater than zero, but it's unclear how formidable that is. And the problem here, again, is that the components are hopelessly entangled. Unlike in a drug trial, the attention and placebo and supposed active ingredients are all mashed together, and they cannot be taken out and dissociated from one another neatly. And so you wind up effectively comparing a real intervention to a useless artificial intervention. It's not a very interesting result when you look at what you find out from a trial like that. I think in most cases, trials like this are not worth doing, and the choice of the comparator is not a good one. Now, I want to take a step back quickly before we get into other mechanistic questions and just say again that when you're doing a standard clinical efficacy trial, the effect size that you get between the intervention and the comparator depends in part on the comparator's formidability. How active or how much change in the outcome does the comparator induce? Some clinically relevant comparators can be quite formidable. An evidence-based treatment might have a big impact on the outcome, and your intervention has to work very hard to do any better than that. Others may have weak or negligible effects on the outcome. For example, usual care sometimes means getting no particular treatment for the problem at hand. It's just whatever advice or laissez-faire kind of interventions that people get. So there's a range of formidability that you may get in a clinical efficacy trial. Now, mediation types of mechanistic trials examine hypothesized mediators or pathways that may help to explain the effect of the intervention. The thing about these trials is that the larger the effect on the outcome, the more variance there is to explain. And so comparators with high formidability are problematic. They're unhelpful. They reduce the variability between the intervention and the comparator. And in a mechanistic trial, the clinical relevance of the comparator really isn't that important. You're not asking about the clinical impact of the intervention. You're asking about its mechanisms. And so relevant, formidable comparators are probably not great choices for these kinds of trials. If you're familiar with the National Institutes of Health Science of Behavior Change program, they have a systematic, what they call experimental medicine type of approach to testing mechanistic questions about these sorts of interventions. They contrast it with a traditional efficacy test where you don't think about mechanisms. You just look to see whether the intervention does a better job on the outcome than whatever you're comparing it to. But in their approach, you identify putative mechanistic targets. You evaluate whether the intervention engages the target and whether the target has valid effects on the outcomes. That's the general strategy of the science of behavior change. The problem is if you use a formidable comparator for this kind of a study, you're going to wind up with small between group effects on the outcome. And that makes it a lot harder to test mediation hypotheses. So the best strategy is to choose a comparator that's not very formidable. Weak comparators favor large effects, and it makes it a lot easier for you to test the mechanistic question. So if you're trying to do the mechanistic question at the same time you're trying to answer the clinical question, you have a conundrum in that the comparator that's clinically relevant may be too formidable for the mechanistic question. The comparator that's weak enough for the mechanistic question may not be clinically relevant. There are comparators that are pretty weak, like no treatment, usual care if it's not very active, and especially wait list. Wait lists in many contexts are the weakest possible comparators. I think I'm missing a slide here. Okay. In any event, those would have been weak comparators that would serve the purpose of that kind of a mechanistic trial. Now, I want to go finally into Dr. Bratt's recently published trial of music therapy for pain management in people with advanced cancer. This is a very interesting trial with many strengths. They were looking both at moderators and mediators, or mechanisms, in other words, of pain outcomes for music therapy. And you'll notice here that what they compared music therapy to was to a social attention control group. And if you look at their article, you see the rationale for that was that they equated the music therapy sessions for contact time and for nonspecific therapeutic factors such as the presence of a caring therapist and empathic resonance. If that sounds familiar, that is the residual effect kind of comparator, the attention control kind of comparator. And in that kind of a framework, you're asking, does the active ingredients of music therapy, whatever they might happen to be, do they perform above and beyond those placebo and clinical empathy and et cetera kinds of ingredients? But that's not the kind of trial that these investigators were doing. They were doing a mediational kind of mechanistic trial. And so because of that, I hate to criticize a colleague here, but I have to ask, was that the ideal choice of comparator? Now, there are a lot of other considerations that you may have to take into account, but this particular comparator may have been more formidable than a wait list or no treatment. It's not very clinically relevant, which is okay in this context. The question arises of why is it necessary to control for attention? Again, is it really the optimal comparator for the purpose of the trial? There may be good reasons, but there are at least reasons to question that choice and maybe to consider alternatives. And so to conclude, low formidability is helpful for a mediation trial. Clinical relevance is vital for clinical trials. And again, sometimes controlling for attention placebo effects in a residual kind of mechanistic trial may be worth doing if it's achievable, but it very rarely is achievable. And so for these reasons and others, you might want to consider doing your mechanistic research before you go out and do a full-fledged clinical efficacy or effectiveness trial. There are a number of different frameworks for choosing comparators. I've been involved in the development of a couple of them. There's also one that's very interesting by Gold et al. I recommend that you use these frameworks because they provide not only helpful guidance, but they provide something to cite when you're having to defend why you chose one comparator or another. And again, there are these two different kinds of mechanistic trials. They may call for different comparators, and both of them may call for a different comparator than a clinical efficacy trial would call for. And again, comparator selection guidance is available in the literature. I recommend that you make use of it to help improve your comparator selection decisions because they can be quite difficult.
So thank you, Dr. Freedland. I just wonder how we could find a solution after listening to your talk. In addition, I would like to ask you, how do you classify the expectations of the participants? Because when we deal with music, it depends in large part of what yes, I will. Okay, I should tell you that while I'm asking these questions, maybe you can also ask a question in the Q&A section. And if we have a few minutes, I will ask one of those. If you are okay, can you see the Q&A question in your Zoom?
No, I cannot see that, so you'll have
No,
to
no,
read
no.
them to me.
I will help you. But let me go back to my questions. Is
Yeah.
how do you classify the question, kind of a consideration of this important factor, which is expectations of
Yes,
the.
I think this is a fascinating and very important question. And my starting point in answering this has to be that expectations are something that the participant brings to the trial. You can try to manipulate expectancies, but you can't guarantee that your manipulation is going to have the impact on expectancies that you want it to have. It may differ from one participant to the next. So there have been trials where attempts have been made to manipulate or equate expectancies between two groups, but you can't really guarantee that at baseline. And even worse, you can't preserve it as people in one group or the other go through different experiences with different interventions or non-interventions. Their expectancies are going to change as they gain experience with whatever it is that you're exposing them to. So that's a very tricky business. And I think underneath the question, there's always concern in non-pharmacological trials about being told, as you mentioned in the beginning, oh, this therapy is only placebo, or it's only expectancy effect, or it's only therapeutic contact. There's nothing more to it. We all kind of have a sense of defensiveness about that allegation that there's nothing more to our work than placebo effects. I personally, I know that drug researchers, and Dr. Colloca can talk in a much more informed way about this than I can, but pharmaceutical researchers have a stake in reducing placebo effects. I happen to believe that many of us non-pharmacological researchers have a stake in maximizing placebo effects. They're enmeshed with our interventions. We can't get rid of it. We don't want to get rid of it. We want to capitalize on it. We want to do better than just the placebo and expectancy and attention effects, but we don't really need to try to sweep them under the rug or control them and show that we've got something special and better. We want to build on them. And so I think the strategy is to allow for the fact that different kinds of interventions are going to have different expectancy effects on different people and run with it. Our job is to try to outperform those kind of non-specific factors over the course of time as we build better and better interventions.
Let's hope we can come back to this issue, because I think that the advantage of the waitlist group,
Yeah.
because they expect the same kind of treatment.
Yeah.
That's exactly the question I find from Matt Bear. What are your thoughts about a waitlist control arm, pros and cons? I just gave a pro.
Yeah. So according to some points of view, waitlist controls can have nocebo effects. People do worse sometimes in a waitlist control condition than they do with no treatment or with just usual care. The reasons for that are not yet fully understood, but I imagine probably the most likely reason is that people assigned to a waitlist control realize that they're going to get some sort of help down the road, and so they don't spend the time on the waitlist doing anything to help themselves. They think, I'll just have to wait this out and then I'll get the help that I'm looking for. I do want to point out, though, that in the majority of the kinds of trials that we do, except maybe for comparative effectiveness trials, the intervention that you're testing isn't the standard of care. It isn't necessarily well-established, strongly evidence-based, known to be really super helpful. It's more experimental than that. And so what you're assigning people to wait for is not necessarily that great. You don't know how good it is. That's why you're doing the study in the first place. And so there is that kind of an interesting twist to waitlist controls in these sorts of trials. So you're holding out something as you're going to be getting this down the road. We don't want to deprive you of it because it's a good thing. You can't really get too far into saying it's a good thing because of the principle of equipoise and the need to maintain some scientific neutrality. But there is that hidden little gem there that the intervention people are waiting for may or may not be all that therapeutic.
I fully agree. I have a few questions coming up, but I think we'll have to move on. I'd just like to say that I think your PowerPoint will be available on the website. Is it correct, York?
Yes, that's correct. And also people feel free to keep posting your questions. We will have time at the very end to answer more questions. But I agree, Dr. Peretz, let's go to Dr. Colloca right now, and we'll save the rest of the questions for the end. Thank you.
Thank you very much, Kenneth, for this wonderful talk. I will continue speaking about placebo effects and
You don't want to be introduced,
Oh, sure.
Dr. Colloca, because you have even two doctorates, one as an MD and a PhD. So let me just introduce you as a professor of the University of Maryland and director of the Placebo Beyond Opinion Center. So she must have more than an opinion on this. And she will give some welcome background on the neuroscience of pain modulation and present her recent timely research on placebo and the use of virtual reality, both being very hot topics, as you can guess. So now it's your, yeah.
Yes, thank you, Isabelle. So just to introduce my talk, we will be talking about placebo effects and control conditions very briefly. And the focus will be on music-based virtual reality, where you will see a series of nuances where we change the control condition based on the research question. We learned today that placebo are very challenging, and placebo effects, placebo responses, especially in music-related research, are such a challenge. And we will understand more about that. And the next part will be, as I mentioned, music-based virtual reality, because seems to be a very effective way to mitigate pain-related outcomes. So from design to mechanism to results. We mentioned extensively with Kenneth how important is research related to control conditions, and the big enemy here is the placebo effects, placebo responses, bias clinical trials. The efforts to create this ideal trial where we control for many things, factor influencing the outcome, has been a challenge not only in music, but in drug development. Just an example, over the last 5-7 years, more than 4,000 clinical trials have been conducted, and only 7 passed the FDA requirement for approval. And of these 7 They are not even new drugs, rather molecular excipients that have been used for other conditions and translated to pain medicine. You understand then that our mindset, our placebo effects or responses are very important. Unfortunately, the placebo research and the clinical trial drug development often are seen as two different entities, despite these factors influence one another. So this is an example of a challenge. We want to develop a new drug, a new intervention, and we have a different possibility. So usually we separate the concept of placebo effects, placebo responses, whereby when we talk about placebo effects, we include a non-intervention arm that in this case can be X, to compare with the active treatment or the positive comparators. However, this can be very challenging, and as we learn today, we have this challenge of creating BC comparators that are as much as possible resembling the active intervention we want to test. In this scenario, there is something that becomes very relevant that often we missed, and the music research is extremely relevant, the psychosocial context where the treatment is delivered. So no matter which treatment we use, can be an opioid, a surgical procedure, an integrative approach to pain, the treatment or intervention is delivered within a psychosocial context, the setting, the interaction with the provider, and all this psychosocial component can influence the pain decoding in terms of top-down, bottom-up pathways. We mentioned briefly in the discussion the role of expectation that often get merged together with placebo. We are now realizing that cognitive expectation or expectancy that can be even unconscious can be separated by the treatment, the pharmacodynamic component, and placebo. So the situation becomes very complex, but yet the mindset or expectation are relevant. I wish to show this study where we had no placebo arms. Rather, we changed merely the setting. The same pain therapeutics was delivered with a pump of infusion, the classical PCA, or with a provider at the bedside influencing the information, the psychosocial context around the treatment. So we use 4 pain therapeutic, buprenorphine, tramadol, that are opioids-based, ketorolac, metamizole, non-opioids. And merely the route of administration, the psychosocial context around the treatment influence the overall pain reduction. Here you see a numerical pain rating for postoperative pain in the hospital. So after removal of lung cancer, what you see here in blue is the sort of hidden administration versus begin aware or begin treated. This difference between the blue and the red bar represents the placebo component. And yet we didn't use any placebo, suggesting that the setting can be extremely important when we want to explore overall outcome benefit, but even when we design a trial. So today we know a lot about this placebo component, where the placebo effects can be driven by verbal suggestion, therapeutic prior experience, observation, contextual and treatment cue, interpersonal interaction. And this will be another lecture, but we know a lot about demographic, psychological factors that influence placebo effects. And the goal is to try to translate this knowledge into music, because learning about the placebo research can help us to optimize and advance music-based research for pain. And I like to do a parallelism. Recently, I was asked to write something about psychedelics. And you may know psychedelics create hallucination, create alteration of the sensorial experience of a patient. And there is an extreme challenge of blind this patient who receives psychedelics. To some extent, the music presents similar challenges because also blinding and finding the right control can be so challenging. At least for psychedelics, and I wonder how much we can translate this into music research, we focus on different strategy, and I wish to comment on measurement of expectation. Despite psychedelics, music presents the challenge of blind participants who receive a specific treatment, yet we can measure expectation when patients enter into a trial. And this can be done at different stage of the trial, especially when we have a long-term trial with follow-up and months of treatment. We can also have a visual analog scale that capture different aspects of expectation and belief, what people believe or desire from a music intervention. And from that, I think we can gain insights in the next, years of music-related research. A question that often we hear also in music is the dose ranging strategy. Can we change the amount of music that we use for therapeutic scope from low, middle, and high doses to somehow optimize the understanding of the therapeutic effects of music? Our lab is approaching now music with the combination with digital therapeutics. We start doing research implementing music inside the virtual reality. For those of you who are not familiar, virtual reality consists in wearing goggles and being immersed in a 3D environment, but most important, also in a 3D sound. That is quite interesting because from a technical point of view, it's richer, beautiful, and captivating engagement with users. The first step was for us to try to understand what is known about virtual reality and pain research. So the majority of research has been done in acute pain and health controls, and less in chronic pain. Our goal was to somehow target this with a step-by-step priority. We start with health participant, acute pain, in particular trauma pain, and now chronic pain. And I wish to show some of these results. So we were somehow lucky to be able to bring into virtual reality two different kind of music-based intervention. Nature music versus opera. For those who are musicians, we use Mozart, the Clemenza di Tito, Act 6. And we decided to have also, after doing a focus group, nature-based music, the sound of the ocean, the fish swimming in the ocean, because we realized that literally there were no people who dislike this nature-based music as compared to the opera, where some people literally love opera, some other people don't like the Clemenza di Tito. So we started with health control, as I mentioned. You can see the setting. People will see these two different content through the goggles or through a 2D monitor. And since we have been talking about comparators, I will explain why we choose this kind of control. So we had the VR ocean with the nature music and the VR opera with the Clemenza di Tito. As control, we decided to use the same identical music without the goggles. And the idea was to have a 2D sound, 2D images, and remove at all the goggles. And also because in the literature of VR, mostly people believe that is attention-related intervention. For us, it was critical to include a task to control for working memory and attention, and we use the two back tasks. Our goal was to see how we can increase tolerance to pain. This is a thermal stimulation, and people had a remoter to decide how much thermal stimulation they would like to receive. So they were self-administered the hot thermal stimulation. And before I show the results, I wish to give you a little bit of understanding of what is the music. So that is the VR Ocean with nature music. Participants see all these jellyfish explore the ocean and listen to the typical sound of the ocean.
We cannot hear it, I'm afraid.
But also, well, I'm not sure I can make this functioning now. Very quickly, I will try to see if we can have the music. It was working before we tried, so probably you have to believe me. But yes, so the other music was related to, again, 3D sound with the opera. And because they are immersed in the VR, participants can approach the performers and listen to Mozart. So when we analyze the data, the first primary outcome was to understand if they can increase pain tolerance. And you can see here the heat pain tolerance limit expressed in Celsius. The VR Ocean result in larger tolerability to pain as compared to VR Opera, the 2D Opera and Ocean, and the memory task. We found no difference with the memory task. And apparently this seems to confirm the data that virtual reality engage attention, but in reality, there is more to the story. Also, we saw that the duration of the thermal stimulation they were able to tolerate was larger in terms of seconds. However, when we look at autonomic measurement, you can see here we observe a peak with both the two-buck task for the memory, attention, and the VR Ocean, suggesting that the skin sympathetic response truly reflects that they were inflicting more pain. On the other hand, when we look at the parasympathetic system, we found that only the VR Ocean relaxed people. And that is what we like to achieve in ER or acute setting where people are in pain, as shown by the skin sympathetic response, but yet they relax. So there was no relaxation whatsoever with the two-buck task, but the music, the nature music, induce an activation of the vagal stimulation, suggesting that despite the pain, people were in this status of relaxation, suggesting that music has an impact in modulating not only the ability to tolerate pain, but also autonomic measurement. When we ask our participant with a visual analog scale, you can see that the VR Ocean decrease pain and pleasantness to a larger extent compared to the control conditions and the attention task, but also what is interesting, we observe emotional regulation. Mood improved with VR Ocean as in nature as compared to any other condition. For those who enjoy opera, we observe similar effects. Mood in the opera likers in red improved as if they were in the nature music, again suggesting that music can be tailored to users' patient preferences. Those who like opera perceive this positive increase of mood as well as reduction of anxiety and so on. So we expanded this line of research and being featured by National Geographic twice and other media. Our goal was to continue and somehow disentangle the factors that influence music And we choose the nature music this time to compare with natural history, the VR ocean with the immersion in the 3D sound versus a sham that is a FDA requirement to prove that something, because merely the placebo effects can be related to wearing the goggles, but also then we ask just to image this nature music or compare with something, again, wearing the goggles, but see a lab. And the paper was just approved this week, and we demonstrate that the nature music through VR continue to demonstrate superior compared to the 2D ocean through the goggles, where we had the sham control this time, and the VR neutral, the distraction and the non-intervention. Importantly, we replicate prior results also with mood, with the difference that pain and pleasantness with the goggle has similar results when we have a 2D through the goggles versus a 3D nature music, suggesting that probably the level of immersion is less relevant than wearing the goggles. And that is interesting from which control should we choose when we study music. For mood, you can see again the nature music at the maximum regulation. I mentioned to you our goal was, okay, nociception in physiological condition, then we translate this into clinical acute pain. We choose trauma pain, people who receive multiple wound and trauma, hospitalized, and we offer the VR ocean that I just showed to you, or a 2D version on a computer versus merely wearing the goggles. And so merely wearing the goggles of the setting become very important. You can see that was even more efficacious than a computer with the nature music. So what we show here is clinical acute pain improve more with the nature music delivered through the VR as compared to the standard music listened through a computer. But yet the goggles are important. Probably they add a placebo component to the music delivered through VR. In this chronic acute trauma patient, we observe a reduction of intake of opioids. They need less opioids when we use the nature music at the bedsides. And also when they were asked what is the most effective for you, they perceive as the most effective the VR nature music. So again, the power of deliver music with new therapeutic digitals like VR can add to the effectiveness of music as compared to music delivered alone or goggles as control. So overall, I hope I convince you that there are strategies to either minimize or maximize placebo effects related to intervention like music. Music engages in multisensorial stimulation, and we can even amplify the power of music for pain by using the goggles of VR. The music delivered through VR is safe, efficacious as a non-pharmacological intervention to mitigate either nociceptive signaling or pain-related outcome in acute and chronic pain. And thank you very much for your attention. For those of you who like to read more about placebo effects, you can download this book for free. And finally, I wish to thank the NCCH in particular that is sponsoring and supporting this research related to music and virtual reality. And thank you.
Thank you, Luana. I have an interesting comment and question from Frank Russo. I don't know if you know him. He's a colleague from Toronto. He says, thank you for this excellent presentation, Dr. Colloca. Can you please comment on your choice of thermal stimulation as your method of assessing pain threshold? Do you have an opinion? It's a little longer. Do you have an opinion about demand characteristics that may arise when an RA is administering this type of pain following something pleasant like prefer music or nature sound? That's really a recurrent question we have actually. It's how to induce, measure, if you like, pain threshold. Is the thermal application the best method relative to the expectations or suggestions by the experimenter?
We found the thermal stimulation very good in the sense that a participant can control the duration of the thermal stimulation and the intensity they can tolerate. In that sense, compared to other form of experimental stimulation to induce pain in a laboratory setting, is very convenient in the sense that participants are in control and they like that very much. But also the thermal stimulation offer the advantage to be extended as much as we need, and the thermal stimulation remind the sensation that people who suffer from neuropathic pain feels, this burning sensation. So we found the thermal stimulation quite helpful in understanding factors that influence music effects.
What kind of instruction do you give that's really, sorry, I can ask you directly the question. What kind of instruction do you give to the participant?
We tell participants that the thermal stimulation will be safe, first thing, because we set the level of the stimulation to an intensity that will never harm them, create any wound. Also, we inform them that the sensation is very much like a burning sensation, as if we have our hands or forearm on the stove, but they can be empowered, decide which level is acceptable for them. Okay. So in that sense, we decrease the level of appraisal anxiety.
Nice.
Yes. And we have another question related more to, by David Denot, the characteristic of the nature music. So the tone, the rhythm, and the nature music wave fish. So we VR built this, and we met the engineer and musician. He is both a musician and an engineer, and some of our collaborators on these projects were also musicians. So they advise us on the tone and rhythm of the music. In fact, now we have another study that we are writing the paper where we introduce a pink noise to have geometric shapes like the jellyfish, but just a square or circle with pink noise to try to understand which component of this VR ocean is so engaging with patient. If it's the nature music, that resemble very much a pink noise in terms of characteristic of the music versus, the wave, the fish swimming. And I can tell you, because we are almost ready to submit the paper, that the pink noise is also very powerful in relaxing patient. And in this case, I say patient because we study chronic pain patient with music delivered through VR. And we add the pink noise as a control for this jellyfish nature music. Thank you for asking.
Fantastic. I hope we're going to have some time at the end of the webinar to discuss further and to give the possibility for others to ask questions. But we now need to turn to Dr. Robb, who is also a professor of supportive oncology at India University, and she will present her insight on what constitutes an appropriate control condition in music therapy for children with cancer. So the floor is yours, Dr. Robb.
Thank you. Okay, so the way I'm focusing my presentation today is to share our decision-making process for comparator selection for a mechanistic study that we were doing with pediatric cancer patients and their parents. So as I move through the presentation, my focus is going to be on describing our intervention to you, including our hypothesized mediators of interest, We'll share our primary aims. As Dr. Freedland had mentioned, the purpose of the study should drive our informed decision-making about what type of comparator. I'll talk a little bit about our choice to use an attention control versus no treatment, wait list, or usual care. Then I'll go over some characteristics of our comparator that aligns with Dr. Freedland's article, where we look at characteristics of comparators, and then acknowledging the relative strengths and weaknesses of our choices. So I just want to start by making sure everybody has a good understanding of what is the intervention that we are looking at and trying to understand the mechanisms of action. So this is a music-based play intervention that's designed to address the interrelated distress that young children with cancer and parents experience during active cancer treatment. One of the things I want to point out is that this intervention is dyadic. It's designed to simultaneously address both the parent and the child's distress. The intervention is grounded in the contextual support model of music therapy. This is important to go over because the theoretical grounding of the intervention is driving both the design of the intervention, but also the hypothesized mechanisms of action. So this is grounded in self-determination and motivational coping theory. And so this model specifies how music can be used to create a supportive environment that encourages engagement, and then in turn, engagement leading to learning and enactment of active coping strategies to manage stress. It's a tailored intervention that's designed to promote engagement and parent-child interaction. And the music engagement, we know that music engagement can positively influence mood and support self-regulation during stressful experiences. I want to spend a moment on the engagement piece because this is one of our primary mediators of interest. So we know that when children encounter stressful situations, they tend to disaffect or withdraw from their environment. And this disaffection is really a natural response to stress. We as adults do that as well. For some children, it can look like withdrawal, like you see in the picture on the left. But for other children, it can also be frustration, anger, or an inability to organize their behavior. What we do know is that prolonged periods of withdrawal and dysregulation are not good for long-term coping and adjustment to illness. So in this intervention, the therapist is using music-based play to move that young child and their parent from a state of disaffection to one of engagement. Okay. So a little bit more on the intervention design. In this study, there were 3 45-minute sessions that are delivered by a board-certified music therapist. The intervention content's tailored based on those theoretical principles that I just talked about. It uses age-appropriate music-based play, and each of these activities is designed to maximize and support parent-child interactions, while at the same time accommodating changes that happen in child symptom distress and energy as they're going through cancer treatment. We also developed a resource kit and parent tip sheets to support independent use. I wanted to share this particular table because as we're making decisions about, our outcome measures, but also our comparator condition, we want to take into account what do we consider to be the essential features or components of the intervention, and what's their relationship to our mediators and outcomes of interest. So this table is outlining in the left-hand column, this is the theoretical principles of what are attributes of the environment that support engagement. And so that informed intervention of different components of the intervention. Here we identified specific things that happen in the intervention itself that we consider to be essential features or components of the intervention, and then work to align those with our potential mediators of interest as well as outcomes. So just to revisit our primary aims for this particular trial, I do want to acknowledge that this was funded by the National Institutes of Nursing Research, was to look at the effects of proximal and distal mediators of active music engagement on outcomes for young children and parents. And our secondary aim was looking at moderators of intervention effects. So first I'll share our conceptual framework. In the left-hand column, you see our antecedents. These are factors that we know are related to our outcomes of interest that we want to make sure we're controlling for, and also include some of our moderators of interest. In the center are proximal mediators, as I mentioned before, our child engagement and parent-child interaction. Our hypothesis being that during these active music making sessions that we're going to see higher levels of child engagement and parent-child interactions that will contribute to changes in our outcomes of interest. We also hypothesized that over time, these distal mediators may also be influenced, such as perceptions about family normalcy, self-efficacy, and independent use of play outside of sessions may also contribute to our outcomes. And this is the actual mediation model that we were testing through the trial. Again, we have our proximal mediators and then our distal mediators. There we go. So I wanted to just spend a little bit of time talking about, so what was our thought process in selecting a comparator for this particular trial. As Dr. Freedland mentioned, the importance of a low formidability for a mechanistic trial. So we wanted to think about that. In many cases, waitlist or no treatment control conditions will provide those high levels of formidability. Being that we're conducting the trial in a cancer treatment, pediatric cancer treatment with moderate to high intensity chemotherapy happening, it gets very difficult to enroll patients and families or to introduce a video camera into a hospital room where you're watching parent-child interactions and engagement without a good reason to be doing that as a comparator. So we had to think through that because these data for engagement and for parent-child interactions are grounded in video analysis, where we're looking at those particular behaviors. So one of the other factors we have to keep in mind, so we needed an acceptable condition in which to observe parent-child interactions and engagement. It needed to also be feasible given the context that we were studying. All right. So I want to describe for you our intervention, and then we'll look at some of the characteristics of the comparator and the pros and cons that came with selecting this as our comparator condition. So our comparator was audio storybooks. This is audio narrated stories. So kind of, if you remember, for those that are older like me, Walt Disney had the little, you turn the page when Tinkerbell rings her bell and they narrate the story on a cassette tape. Then it moved to CDs, and now you just watch them online. But anyway, there's audio narration along with an illustrated storybook that parents and children can look at and follow along and enjoy that as a shared experience. So it was a 30-minute session, also delivered by our music therapists. Children could choose from 3 different books to listen to with their parent. They listened to the stories together. They received a kit to keep and use between visits as they desired. And this did provide a shared parent-child experience that had audio-visual stimulation, but wasn't a music condition. And also, although not as important in a mechanistic trial, it did control for some attention from a trained clinician. It was at the same frequency, had a similar duration, but limited involvement from the clinician and really no clinical content at all. I think one of the positives for this particular condition is that we've been able to demonstrate that it has low forbidability on both our outcomes of interest and our mediators of interest. So just to go over some of the characteristics of audio storybooks as a comparator condition, we did early pilot studies that indicated that audio storybooks did have low formidability on both child engagement, parent-child interaction, as well as our outcomes of interest. But at the same time, it was feasible and acceptable for children and parents. And that in turn supported high enrollment and retention rates in the trial. We used audio storybooks, as I mentioned before, to control for attention from a provider. Actually, that's quite minimal in that they set up the story and then remained present, but it did have similar duration and the same frequency. It also controlled for time spent in a shared parent-child activity and allowed us to capture the data that we needed on child engagement and interactions. In terms of its clinical relevance, it mirrors real-world programs in terms of offering supportive, age-appropriate care in pediatric hospital settings, but it's not a clinical intervention and it's not it doesn't have any clinical content. In terms of stringency, oftentimes our parents and families would indicate that they didn't really know whether they were in treatment or control. Sometimes people would mention that they thought they were or they weren't. We had very high retention rates. So the study is introduced as being interested in understanding how different music and play activities can be supportive to parents and kids during cancer treatment. So our comparator condition did offer something that seemed reasonable and was enjoyable. For uniformity, we did fidelity monitoring to ensure that they were being delivered as intended. And in this slide, this is actually showing you one of our graphs from a moderation analysis. For the control group, which is in yellow, you can see that the parents who reported high levels of distress in their child at baseline reported the highest levels of traumatic stress symptoms post-intervention. And this is important because this relationship that you see here in the graph is consistent with descriptive literature on traumatic stress symptoms in parents of pediatric cancer patients and suggests our control group was functioning as intended. In contrast, our AME group, which is in blue, you can see a stabilizing effect of AME on parent traumatic stress symptoms, where parents who reported high levels of distress in their child at baseline reported significantly less traumatic stress symptoms for themselves than in the control group. So the buffering effect is really important and identified a subgroup of parents who might derive the most benefit from the intervention. And I'll just mention that both of the articles listed here, if you're interested in the actual outcomes about the mediation and moderation analysis, these are open access articles that are available to you online.
Thank you so much. That was really interesting. Maybe I'll give the floor to Dr. Colloca and Freedland to ask you questions. I didn't do that earlier, but maybe I should do that while people are asking questions. I don't have any specific questions for Dr. Robb so far in the Q&A. So would you have a question for Dr. Robb first?
Well, I don't have a question, but I do have a comment. I think the comparator selection process that Dr. Robb and colleagues went through was very thoughtful, and it illustrates that there are pros and cons to different choices. It's not always possible to come up with a choice that's ideal in every single dimension in every respect. What I will often tell people is if the compromises and trade-offs that you have to make are too extreme, you may have reached the point where you have to admit, this is not a study that I can actually do. I can't actually ask the question that I set out to ask. But if the compromises are more modest, you may be able to answer the question, but with limitations that you'll obviously want to acknowledge in the paper that results from it. So I just want to commend the investigators for a very thoughtful analysis of the variety of reasons why you might choose one comparator or another.
I have interesting questions coming up now from Victor Fernandez Duenas. I have a question which is, using audiobook as comparison, it can be confusing for people who really like to read, like the parents who like to read instead of hearing. What do you answer to that?
Yeah, it's a great question. I think what we did, because we were interested in controlling having a low formidability for child engagement and parent-child interaction, the audio narrated storybooks helps to hold that level of and type of engagement more constant than if you have, say, a parent who is reading to their child, and then you get much more variability in terms of the amount of engagement. So we made the choice of using audio narrated storybooks for that reason, and encouraged parents, if parents had questions about that, we would talk about how, because we're doing a study, we're really interested in keeping the experience the same as much as possible across our families. And so we would encourage you to listen to the books and engage your child as you typically would, but we did not, we tried to discourage the option of reading aloud, if that makes sense.
Yeah, it does. Okay, maybe I'll open for the questions for everyone. Would you like to ask a question among yourselves? Before I have two other questions for you.
I have a question about expectation. So, do you measure expectations when you run these trials in both the parents and the children?
We didn't, and that's a really great point, and something that would have been, in retrospect, a great thing to do.
But you did have something like belief scale. What was the belief scale from the parents?
I think there were beliefs about that weren't related to expectation of the conditions, but had more to do with like parent self-efficacy, their abilities to support and manage their child's distress. That's a really good point, Luana. Thank you.
Mm-hmm. Mm-hmm. So I have a question for everyone, I suppose. It's from Darina Petrovsky. She's asking how to present your choice for a control condition in a grant application. That's really pragmatic. Yes.
Yes, I think this is really critical. No matter what you choose, somebody is going to be unhappy with it on the review committee. And so that's one of the reasons why I think it's really important to take a look at one or another or several of the guidance frameworks. And you don't necessarily have to pick one, although that can be helpful. But it gives you a way to make an argument for why you did what you did, why you chose the comparator that you chose, and why you didn't choose other alternatives that might seem like, to a reviewer, might seem like the obvious choice or a better choice. So, for example, if you decide that you want a usual care comparator for your study, but you can anticipate that one or more of the reviewers is probably going to say, well, that's no good because you're not controlling for attention. You want to have an argument lined up for why you believe that it's better not to control for attention in the context of this trial. And you want to have something to cite to back you up on that. And so that's why those guidance frameworks can be very helpful in that context. I also think it can be very helpful to lay out when you're people typically go into much more length on describing the experimental intervention than they do on the comparator. But I would advise say enough about the comparator that reviewers can understand its characteristics well enough to know that this is a reasonable choice and maybe a better choice than some of the other alternatives.
May I add something? I totally agree with that statement and show the willingness to discuss why you use one comparator or control condition as compared to another, demonstrate that you are aware of the complexity. But also, I show to you that, for example, across the different music-based virtual reality studies, we had a different control or comparator based on the research question. So again, it is important to have on the ground a person who understands how to design a trial so that you can motivate and justify why you use a certain control or comparator.
And you've touched on a really critical point, I think, that you might compare the same intervention to different comparators at different points in your research when you're asking different kinds of questions. And that's okay. Sometimes people believe that there must be a one-size-fits-all, or they believe that if I've compared my intervention to something in one study, then I'm stuck with that comparator forever. That's the only thing I can ever compare it to. And that's not the case. Again, you choose the comparator based on what's most informative for the study at hand, even if that's different than a comparator that you chose in a previous study.
I have a technical question from Teresa about which website is it? I mean, yes, you mentioned the resources, Dr. Freedland, and maybe you will be able to find it in the PowerPoint that will be put on the website later on.
Yeah, there are references to the different guidance frameworks. I can't point to a website, but there are articles that you can obtain that will provide guidance. I see Dr. Petrovsky has asked an interesting question as well about mechanistic trials. Is it better for the comparator condition not to engage your mechanism at all, or to still engage it, but to a lesser degree compared to the music intervention? And what I would say is, in a mechanistic study, the ideal situation is if the difference between the intervention and the comparator is like flipping a switch on and off, or A and B. That's the way things work in an actual laboratory experiment, where the experimenter has control over what the subjects or participants are exposed to. They either get this or they get that. It's a black and white difference. That's much harder to do in clinical research, where you're using interventions rather than laboratory manipulations to affect your outcomes. But the closer you can get to that experimental ideal, the better. So I would say in this context, the comparator that you want is the one that has the least effect on the mechanism of interest. You're better off having no effect if you can get it, but if that's not possible, having as little effect as possible will enable you to see the biggest difference in the mechanism between the comparator and the intervention arm.
All right. Dr. Robb, would you like to add something?
I appreciated Dr. Freedland, your comments on and what you offered about changing comparators based on the research questions that you're asking. I think a lot of times what I've run into too is that pushback from certain reviewers on uses of waitlist control and usual care, and then how do you control for usual care? I always have to do multi-site studies, so if I have 4 different institutions, usual care is going to vary. Can you talk a little bit about, I think you addressed it a little bit in terms of the grant writing aspect, but the pushback that we often get or see from different reviewers about the use of a usual care condition?
Right, and it's not only about that. There's often pushback on review committees about other comparator considerations, such as some people believe strongly that you always have to control for attention, and I would argue that it's often counterproductive to control for attention. It's almost like a religious belief. The ideas are very strongly held, and I've done some research into the history of all of this. Where did these ideas come from that many reviewers and many investigators hold so strongly? Like the idea that, well, usual care is a bad comparator because it's messy or it's heterogeneous or you don't know what it includes. Where did those ideas come from? And I found some of them have their roots in misunderstandings of studies that were done in the 1940s and 1950s. Some of them really came as reactions to concerns, like the idea that, well, non-pharmacological research isn't very rigorous, it's not very good, we have to get tough, we have to make everything very difficult and formidable, or we won't look like our drug research colleagues. It really is that kind of defensive posture about this research that makes people so tenacious about some of those beliefs about comparator conditions. And I think the antidote to that kind of stubborn hold on certain ideas about what is an appropriate comparator is to think through it, to weigh the pros and cons, to develop a rationale, to use the guidance frameworks, and to say, look, this is why we're doing this. And you find often, I think, that reviewers, even if they don't agree with you, they at least will respect your logic and your thoughtfulness. And I think that's about the best you can do. And it's also worth bearing in mind that you have at least one chance to argue with reviewers. You may want to cave in the second time, but at least the first time, go in doing what you think is the scientifically most appropriate and the best approach, and deal with the fallout after that.
Oh, we will end up on these very wise words. You okay, Brad? Maybe you'd like to add something?
Just to thank everyone, all the presenters, for a fantastic webinar and the lots of just really fantastic information for all of us to think about. And I agree with you, Dr. Peretz. The final words of Dr. Freedland were very helpful and gives us, I guess, the courage to go in to our with our grant applications to review panels and trying to argue as best as we can. So with our next grant applications, we will have you in mind, Dr. Freedland. And I would like to thank everyone for attending. This webinar is recorded and will be made available on our website within the next few days. So you can always find our recordings of our webinars there. So thank you very much for joining and have a wonderful rest of your day.
Thank you.
Thank you.